Just go ahead and get started. Well, welcome everyone. Thank you for being here. So I was asked to come and talk about substance use during pregnancy. So I'll be talking about the impact on women's health, but also, of course, on the developing child. If I do welcome, I know Taylor mentioned people are muted. I welcome any comments or questions throughout, but I will also make time at the end for any questions. And I think we'll try and aim to be done by maybe like 1:45, 1:50, so we can have a little time at the end for questions. So yeah, I'll go ahead and get started. I'll introduce myself. I'm Kallio Hunnicutt-Ferguson. I am a clinical psychologist with the center that Taylor works with, Center for Maternal Substance Abuse and Child Development. And I work in that capacity as a prevention specialist. But I also have expertise in working with women with substance use disorders. So that's a lot of what I do clinically. So always just want to acknowledge some of our funding sources. So some of the material that is discussed today is supported by the resources listed here and organizations. Just to provide a little bit of overview for those who may not be familiar with our center. We are a center in the Emory University School of Medicine, and we have a few different missions. We do developmental research and brain imaging. We do the prevention work that Taylor and I are a part of, and then we also have a diagnosis and treatment clinic, the Emory Neurodevelopmental Exposure Clinic, where we provide services for individuals and families who have been affected by prenatal exposures. And I have some resources listed at the end that can also be shared that include how to refer to our clinic if you have somebody who you think has a child, or we serve individuals up to age 21. So if you have someone who has a known exposure who you would like to get evaluated and potentially connected with resources, there will be information at the end. So just to provide an overview of what we're going to be talking about today, so we're going to learn about how substance use affects women's health and identify the substances used most often during pregnancy. We also will aim to better understand the ways that specific substances used during pregnancy may impact the developing child. I'll talk about what we know and what we don't know. And then finally, we'll understand how neurodevelopmental disorders are diagnosed related to prenatal substance exposure. So this could be a talk in itself, so we'll just kind of touch on that topic. And again, I think Taylor put it in the chat, but if feel free to use the chat for any questions that may come up, or also I'm happy for you to verbally ask questions as well. So I always like to start by talking about substance use disorders and some of the stigma that is associated with substance use disorders. I think this is particularly relevant when we're talking about women's substance use disorders, as we'll talk about momentarily. So we know that the majority of the population uses some kind of addictive substance, whether that's even if it's only caffeine. And so we think about substance use problems on a continuum from no problems to mild problems to more severe problems. And when we're looking out for substance use that is becoming a problem, we typically see things like repeated unsuccessful attempts to cut down on the substance use. So making a plan, okay, I'm going to stop at this time, and then repeatedly being unsuccessful with that. Developing a tolerance to the substance, so needing more of the substance to get the same effect, or experiencing withdrawal symptoms when you stop using the substance. It can also, often we're looking at consequences of the substance use. So that could be things like legal consequences, like driving under the influence, getting a DUI, or it could also just be having negative impacts on one's relationships and because of substance use, work functioning, and so we'll be thinking about, and when we work with people with substance use problems, we're sort of keeping an ear out for these kinds of issues. And if we think about pregnancy specifically and substance use during pregnancy, if somebody has a substance use disorder, it may be that they want to cut back or stop using the substance, but are really having a difficult time with that because they are have a substance use disorder related to that substance. And though the field has made some progress, as I mentioned before, there is unfortunately still stigma associated with substance use problems. And there's at times a perception that somebody should be able to just give up the substance, that willpower should be enough, or that if somebody was a better person, they could just figure it out. But we know that substance use disorders are a chronic brain disorder, um, and are a treatable medical condition. And so that's sort of the good news here, is that we know that we have good treatments if we can get people connected with them. And of course, as we talk about substance use during pregnancy specifically, there's even more stigma that can affect women's comfort with disclosing that they're having a problem with the substance, as well as their desire or willingness to seek out treatment. Often there's a fear of consequences, that their either current children could get taken away, or that their baby, once it's born, could get taken away. Um, there are many other barriers, of course, as well, related to access to care, financial resources or lack thereof, um, difficulty kind of figuring out childcare or caregiving responsibilities, if the woman has children already. And it's also common that women who are using substances or have a problem with substances have a partner who also has a problem with using substances, which can then be another barrier to stopping or getting care. So we've seen some changing trends over the years in substance use in women in particular. So in the past, men were more likely to report the use of alcohol and drugs, but we have seen over the years that rates among women are rapidly approaching those of men. Men do still report higher use of certain substances like alcohol, tobacco, and most illicit drugs, but women and men are reporting more similar levels of opioid misuse in particular. And when we look at teen substance use, there are no statistical differences in the amounts of substances reported. And when we look at substance use, and this is among women in general, not specific to pregnancy, but is important to look at because we know that often women become pregnant before they're aware. And so we need to look at kind of substance use before pregnancy, because those early stages of pregnancy before somebody knows that they're pregnant may involve exposures that are unintentional. So this is from the 2021 National Survey on Drug Use and Health. We see alcohol by far is the most commonly used substance, and followed by tobacco products. And then marijuana is becoming, and cannabis products is becoming a lot more common, especially as marijuana is legalized or decriminalized in many states. Really, marijuana use is on the rise among all groups, but we see that about 16% of women are reporting past year marijuana use, just almost similar rates to those reporting tobacco use or tobacco product use. And then much lower rates of use of other substances, though we're seeing somewhat higher rates of prescription opioid, there's a little typo there, but prescription opioid use. So that includes things like oxycodone, that somebody might be misusing, not using as prescribed. And we know that women experience some unique health effects of substance use. So women see a more rapid progression to substance use disorder as compared to men. So basically what that means is that once they start using a substance, they more quickly move to problematic substance use compared to men. We see higher blood alcohol concentrations in women with the same amount of alcohol ingested compared to men. And then some unique other negative health effects like increased risk of certain kinds of cancer related to substances, fertility issues, greater risk of liver disease, and heart damage, as well as increased risk of mortality. And as we've referenced before, women may be less likely to seek treatment for a substance use problem for the range of reasons that we touched on earlier, including stigma. So just to summarize, we generally see that women use substances at lower rates than men, except for with opioids. Alcohol and tobacco are the most commonly used substances with women, with marijuana being the most commonly used illicit substance. Women in that 18 to 25 age group are using substances typically at the highest rates, which is important to know as this is a good proportion of women of childbearing age. Women are disproportionately affected by opiate misuse via prescription medication as well. So they are prescribed opiates at higher rates compared to men. And so that might be one explanation for why we're seeing those higher rates of opiate misuse. And prescription opiates are responsible for by far the highest rates of overdose and death. So that is when we're thinking about substances and their negative impact, opiates are one that we really need to be attuned to from a prevention and treatment standpoint. So I'm going to move now into substance use in pregnancy specifically, but just wanted to pause to see if there are any questions about what I've covered so far or anything anyone wants to hear more about. Okay. All right. So we want to next think about as we think about substance use during pregnancy, why might women drink alcohol or use drugs during pregnancy? And so there are a number of different reasons why that might be. They may not be aware that they're pregnant. So we know that actually about 50% of pregnancies are unplanned. And so if we go back to those rates of substance use among women in general, it may be that they're using substances and don't even know that they're pregnant. They may be unaware of the severity of damage that the substance can cause developmentally. It's very common that people have these normative comparisons, like, I know this woman who drank throughout her pregnancy and her kids were just fine. There may be normative substance use in the woman's social group or family. So if everyone around them is using substances, they may not realize that, okay, that's maybe not something I should be doing. They may be using substances to cope with difficult life situations or have a substance use disorder, which we've already touched on. And again, they may have a fear of consequences of disclosing their use, which can get in the way of getting help. And physicians often don't ask, or they may not know how to help if somebody is coming to them reporting substance use. And we know that a pregnancy is potentially incentive to quit, but it can also, for some women, be added stress and a fairly short time to change behavior, social life, and relationships. And so at the most, it's 9 months to make a change, but there's also that period of time potentially before the person knows that they're pregnant, or we don't always, there's just not a ton of time for them to, especially if they're have made attempts and have that substance use disorder where they've made attempts to stop and it's been unsuccessful. And we want to think about, probably everybody here has a sense of why it would be important to think about this, but just to cover some of the points here. So there can be, because of those normative comparisons and also just mixed messages in the media and elsewhere, there can be confusion over what the right approach to substance use during pregnancy is. We know that with marijuana, for example, many more people are using marijuana during pregnancy, and there's just not a lot of data about kind of how this affects development or women's health specifically, because it's not been legalized in many states up until more recently. And there also can be confusion with alcohol, for example, of maybe it's okay. Is it okay to have a drink during pregnancy? Maybe it's okay to just have one. And so that confusion can then lead to mixed messages about what's recommended. We do know that the majority of DFACS referrals in Georgia involve substance use. So we think about up to 80% of DFACS referrals involve some type of substance use. And these rates really have increased over time. And we know that it's a larger affected group than we realize. So estimates range from about 0.6 to up to 32% of those prenatally exposed. And then we know for fetal alcohol spectrum disorders, it's about 10 to 15 cases per 1,000. That in higher risk groups specifically, such as those that may be entering foster care. So looking at substance use rates specifically among pregnant women, so we see that the good news is that there's a pretty big difference between the green is not pregnant and the purple is pregnant. So we see quite a bit of a reduction in substances across the board from pregnancy, not pregnant to pregnancy. And we still see that that there about 10% of women are reporting alcohol use during pregnancy, about 8% are reporting cigarette use, and 8% reporting marijuana use. Likely these are underestimates for some of the reasons that we've talked about before. And we also know that among certain high-risk groups like teens and young adults, that these rates are likely higher. And we also know that adolescents and young adults who are using substances are more likely to engage in unprotected sex. And so therefore may be more likely to have an unintended pregnancy that has an exposure. So any questions about what I've covered so far in terms of substance use during pregnancy? We'll be going through in a moment some of the more specific developmental impacts of substances. All right. Okay, so this chart shows some of the data that we have for Georgia specifically. And again, we believe this is likely an underestimate. This comes from the Georgia Pregnancy Risk Monitoring System. And we think that this is likely an underestimate just because this is a self-report. This data comes from a self-report survey that goes out to women who had a live birth and relies on the woman to respond, and also to report accurately. And so we know that in general, in substance use assessment, people tend to underreport their substance use, and this is likely even more true during pregnancy. But we see overall similar patterns of substance use. So we're seeing the highest rates of reported alcohol use during pregnancy, followed by tobacco and e-cigarettes, as well as marijuana. But we're also seeing pretty high rates of opioid prescription use. This isn't necessarily opioid misuse, at least from what the women are reporting, but it just gives us a sense of kind of the number of opioid exposed pregnancies. So just to summarize, legal drugs like cigarettes and alcohol are the most commonly used substances during pregnancy, followed by marijuana and prescription drugs. Cocaine, methamphetamines are next, and then opiates like heroin are last. However, the majority of women who do use alcohol or drugs in pregnancy and during breastfeeding do tend to use more than one drug. So the norm really is that somebody is using multiple substances. And I have this slide in here. I will say I'm not a lawyer. I'm not an expert in legal and mandatory reporting issues, but did want to just mention this because I think sometimes it's helpful for those working in healthcare and that may not know this information, but may work with women who are reporting substance use. So it is not illegal to use substances during pregnancy. However, reporting issues, and this is in Georgia specifically, reporting issues can arise after the birth of the baby if, for example, the birth giver's ongoing substance use is judged to put the baby at risk, if the baby has withdrawal symptoms, or if the baby has negative effects from exposure to substances like fetal alcohol spectrum disorder. And at that point, it's possible that an investigation could come up. Ideally, support is provided for the substance use problem and to keep the family together. Though, of course, there are instances where that's not possible. And other variables can also contribute beyond substance use, like homelessness, domestic violence, or neglect. All right, so we're now going to move into the impact of maternal substance use on the developing child. And so this is a complicated model, and there are many contributing factors. We know that the developing embryo and fetus are vulnerable to many different agents, and some examples are listed here, things like the prenatal environment, social factors, stressors like legal issues, prenatal care or lack thereof. Substance use is one among these many different factors that can impact the developing child. Genetics, of course, maternal characteristics. And the impact on the developing child really depends on the type of agent that's used, when it's used, for how long, the amount of exposure. And so again, in addition to substance use, there are many other factors that can also contribute. And there's a lot that we don't know about how much and when, and of which substance or which combination of substances. There's just a lot of variables that can contribute. And so there's the prenatal environment, and then there's also the potential outcomes that it can affect, like reduced fertility, fetal wastage, preterm birth, birth defects, slow growth retardation. But then there's also the postnatal environment, so stressors that may occur in the postnatal environment, like legal issues, social factors, nutrition, social service involvement, substance use in the partner, and all of this can interact to affect long-term development. So developmental and medical, social, and educational outcomes long-term. So again, all of this really is to say that it's very complex, and it is likely not just one contributor when there are effects on the developing child. And so this is just a summary slide that goes into the main kind of findings that we have related to each of the most commonly used substances or classes of substances when they are used during pregnancy. So we'll go into each of these in a bit more detail. So going back to the rates of substance use, so just as a reminder, about 15% of women who are not pregnant are using some form of nicotine product, and about 8% report use of these products during pregnancy. And we've seen effects of nicotine use during pregnancy on negative outcomes, both in the short term as well as the long term. In the short term, we've seen increased risk of preterm birth, low birth weight, increased risk of SIDS. And in the long term, we've seen auditory perception, language development, and increased risk of conduct disorders. So nicotine and tobacco use and specifically have these consistently negative effects that have been found across many studies over the years. Looking at cannabis, we've talked about how rates are really on the rise among all groups. And I just like to kind of contextualize this within the increased cannabis legality by US jurisdiction. So this image actually comes from Rolling Stone magazine, but it was just the most recent image I could find because things are changing so frequently. Marijuana use is on the rise among all groups, but also among pregnant women. And we see in this graph or in this diagram, some people already know this, but in Georgia specifically, there are some types of THC products, particularly those for medical use, that are legal. But of course, we also know because of the increasing legality across the country, there's just more access. And we know that THC concentration levels, so THC is the mind-altering chemical in marijuana, that is the levels of THC concentration have increased quite a bit in the last 25 years. And we also know that there's a wider variety of cannabis products and forms of ingestion. And there are some forms of ingestion that are available that can be purchased from the drugstore or the smoke shops or bodegas or any kind of store like that even in Georgia. And so there's just the potential for a prenatal exposure to many different forms of cannabis or many different types of sources of exposure. And we also know, I think this is maybe the most important point about marijuana, given what we know about its developmental impact or lack thereof, is that marijuana is very often just the tip of the iceberg. So marijuana use during pregnancy is very often accompanied by other forms of drug use. So about 50% report smoking more than 10 cigarettes a day. 12% are concurrently using opioids, 10% using stimulants, and about 4% of those reporting marijuana use during pregnancy are also reporting alcohol use. And actually, specifically alcohol-related diagnoses. So not just that they're reporting alcohol use, but that they have an alcohol use disorder. And so if someone is reporting marijuana use, it needs to prompt us to be thinking about and asking about the use of other substances. So in terms of developmental impacts of marijuana specifically, so we have not found any clinically significant effects in the newborn period. So we have not seen increased risk of birth defects, and we have not seen any specific effects on growth retardation. And there are some studies that have looked at longer term outcomes, and there are some people that have brought up, is there something similar to fetal alcohol spectrum disorder? Is there a similar condition for cannabis exposure. So certain researchers have suggested, is there something called fetal cannabis syndrome disorder that accounts for the increased rates we've seen in some developmental disorders over time. However, a recent review found variable results between prenatal marijuana exposure and children's outcomes, and their conclusions were that no consistent short or long-term effects of cannabis use on its own could be found. And so really the most important takeaway here is that because cannabis is very often used with other substances, and there are other factors like socioeconomic status, stressors in the environment that accompany it, that prenatal marijuana exposure in itself alone could not explain the effects that we're seeing. And so essentially what they're saying is that it's these other factors, whether it's the use of other substances, or other factors in the environment, that explain those outcomes rather than the prenatal marijuana exposure. So in looking at the effects of prenatal alcohol exposure on the developing child, so alcohol, particularly when used heavily during pregnancy, is one of, if not the most harmful substance to the developing child. We see a whole host of negative outcomes, perinatal problems like increased risk of preterm birth, physical birth defects, growth retardation, global cognitive effects, specific neurodevelopmental impacts, academic deficits, long-term effects on health, as well as fetal alcohol spectrum disorders, which is the diagnosis that would be given when certain patterns are seen in the child. And so the most conservative prevalence estimate for FASD ranges from about 1 to 5%. So if we think about like in a school setting, in 1,000 children, about 11 to 50 of those would likely have a fetal alcohol spectrum disorder. And so I think this is important to know in just knowing that it may be a diagnosis that's that may be missed or underdiagnosed. And we know that these findings present a higher estimated prevalence for the US than has been reported previously, and is consistent with studies that have been carried out across the globe. So I think often for those who do know something about FASD, they often think of this as a childhood disorder, but really it lasts a lifetime. So we see effects across the lifespan. There are primary disabilities that are present throughout the life, including intellectual deficiencies, developmental and learning disabilities, cardiac problems, vision and hearing loss, facial dysmorphia, motor dysfunctions, and then secondary disabilities that sort of result from these primary disabilities that include school failures, mental health conditions, vocational failures, and substance use problems. Moving on to the effects of opiates on the fetus and the newborn. So the most consistent effects we've seen are in the short term. So there are increased risk of growth reduction, increased risk of stillbirth, as well as neonatal opioid withdrawal syndrome, NOWS, or as it's sometimes called, NAS. And this is the most recent data that we have. It's a little old now, 2016, but across Georgia, we see that it's a little hard to see in this diagram, but the darkest blue color is the counties with the highest rates of NAS. And so though we see higher numbers of NAS in certain other counties, the highest rates, meaning the highest numbers of or cases of NAS per the population, are seen in these more rural counties. So that includes Jeff Davis, Webster, Pulaski, Stevens, and Johnson counties. So additional effects of opioid use during pregnancy really focus on that NAS or NOWS, so those short-term withdrawal symptoms. So essentially the baby is going through withdrawal if opioids were used right up until the end of pregnancy. And this includes symptoms of withdrawal that anyone would experience after stopping opioid use. So gastrointestinal symptoms like vomiting or diarrhea, increased heart rate and sweating, central nervous system activation or effects, agitation, sleeplessness, high-pitched crying, reddened fingertips and toes, and respiratory distress. And the good news, though, about NAS or NOWS is that in some cases it's dangerous, others not, but typically it resolves as once the opioids are out of the infant's system. So it doesn't typically last more than a week or so. And we don't really have any data to show that there are negative long-term effects of opioid use during pregnancy. It seems to really be more that short-term withdrawal effects right after the birth. I think this is another piece of good news, that though we're seeing higher rates of opioid use and there are negative and risks associated with that, like increased risk of overdose and maternal health effects, and then the withdrawal symptoms for the newborn, we're not really seeing the long-term negative effects. Alternatively, with stimulants, so cocaine, amphetamines, methamphetamines, we do see both short and long-term negative effects. So in the short term, we see increased risk of growth retardation, risk of fetal wastage, increased risk of miscarriage or stillbirth, and preterm birth. And then longer term effects of stimulants include not necessarily longer term effects on growth or intellectual ability, but there's this consistent finding that prenatal exposure to stimulants affects an alteration in arousal regulation or stress responsivity in the infant and developing child. And we see this really actually persisting throughout childhood. And we've even done some imaging studies in adolescents where these effects were confirmed through brain imaging. And so I'll just say, to summarize, tobacco and nicotine products, alcohol, and then stimulant use during pregnancy have the most consistent negative effects that we have seen throughout research and studies that have been done. And then I don't know if any individuals here have experience sort of needing to ask about or assess prenatal substance use. I know as doulas, you'll be certainly working with women who may be using substances, and there can be hesitancies in healthcare providers about asking about substance use. And I just wanted to mention briefly, there are a couple of tools that can be used in very simple. So this one on the left, the substance use risk profile in pregnancy measure, is just 2 questions, specifically asking about alcohol use during pregnancy as well as drug use. And then there's another measure, the 4Ps plus, that is does have some copyright issues and requires a licensing fee, but is another assessment tool. But I think of, in general, the most important thing being asking open-ended questions, asking questions in a way that makes it easy to respond with a yes, so that people feel maybe more comfortable to be able to acknowledge or report their substance use, because we can't refer people for treatment. We can't refer children to services if we don't know about prenatal exposures. And so the last section that I'll talk about is just, again, briefly, we'll talk about um, fetal alcohol spectrum specifically um, and how it is diagnosed. And then I'll touch on some of the interventions that are the areas of intervention for kids with fetal alcohol spectrum disorder. So fetal alcohol spectrum disorder is diagnosed by a medical professional through history of prenatal exposure, a certain pattern of facial features and growth, as well as brain impact. And so I won't go into all of this because, again, this is diagnosed and done by a medical professional. But there is a certain pattern of facial features that is typical of individuals who have fetal alcohol spectrum disorders. We're also looking for certain patterns in growth related to the neonatal period, which does not include head circumference. And there are different, depending on the classification guideline, there are different growth cutoffs, but so it's either the 3rd percentile or 10th percentile, depending on the guideline. And then we know that we're also looking for damage to the central nervous system, which we know is the basis of the behavioral effects that we see of fetal alcohol spectrum disorders. So that includes a reduction in overall brain volume, malformations and reduction of volume of gray and white matter, a thin or missing corpus callosum, alterations in brain activity and connectivity. And so we'll talk in a moment about what that kind of means from a behavioral standpoint. And this is just to talk about the burden of care for children with FASD, that there's a lot that the families have to do to support the child. So that includes physical health and motor effects. They may need eye exams, cardiology, neurology, physical therapy. There may be feeding issues. And then there are the developmental and cognitive effects. They may need individual speech and OT. They may need cognitive rehab, behavioral and social effects like parent education training, child therapy, psychiatric care, and then they may often need academic and social supports. And so in terms of the specific neurodevelopmental impacts, we talked earlier about arousal regulation difficulties and also the brain neurodevelopmental effects related to connectivity. So we think that there is this common factor that influences the behavioral deficits that we see that relates to impairments in arousal and regulation of arousal. And so this contributes to this pattern of impairment related to intellectual ability, so delays in development and cognitive deficits, academic deficits like learning disorders or academic underperformance, as well as behavioral deficits like attention problems, externalizing behavior, impulsivity, and sometimes self-injurious behavior. And so what do we mean by arousal regulation? So when we talk about arousal regulation or difficulty regulating arousal, this looks like a greater stress reactivity in the infant and child. There may be sleep disruption, more negative emotions. And as children move into the school years, we may see mood lability, like up and down moods, negative moods or irritability, frequent behavioral outbursts, academically difficulty encoding new information or shifting attention, as well as sustaining mental effort. So it might be hard for them to start a task and stick with it for the amount of time that's being expected in school. And then impairments in inhibition or impulse control. And so I'm going to try to move through this fairly quickly because I want to leave time for any questions that people may have. But just briefly, I wanted to mention some of the interventions. So the main areas of intervention that we think about for kids and families affected by prenatal exposure to alcohol include skills to help them with those self-regulation difficulties that I just mentioned. And the good news is we do have interventions to help with that have shown positive outcomes. Support for academic skills, um, targeted interventions related to learning about safety, things like phone safety or even fire safety around the home, and then social skills training, which might be often is in the form of social skills groups where they can learn from peers. And so to just summarize, again, this could be a talk in itself, but in terms of intervention for children affected by prenatal alcohol exposure, we want to be really the first thing is asking about maternal substance use during pregnancy. That's the first thing that we can do is get that information and learn to do so in a way that is supportive of women being able to open up about that, given the stigma and potential barriers. We can also be screening infants and children for the effects of prenatal exposure and postnatal neglect or abuse. Refer children for further evaluation if there are signs or symptoms of concern. Support caregivers in getting children evaluated and in obtaining recommended services. So there are these effective interventions, but they do require family support, and it can't happen in a bubble. So really going back to that burden of care slide, there's a lot of care team members that often have to be involved. We want to be informed about available resources that can support treatment for infants and children and work effectively with Babies Can't Wait, school systems, and other providers. So I'm going to take a pause there. We have a QR code here that we'd love to get everyone's feedback before you log off today. But also want to just open it up for questions or comments. And then maybe as I can come back to this slide, I'll kind of go through the resource slides quickly as we're finishing up. But any questions that I can answer about any of the content we've covered today? I know there's a lot of content that we've covered. We have state level resources that include Department of Community Health, Division of Public Health, like Babies Can't Wait. The Emory Neurobehavior and Exposure Clinic that I mentioned is a multidisciplinary assessment and treatment clinic for complex problems. We treat children 0 to 21. And the focus is not just on treatment diagnosis. We have this multidisciplinary perspective that we're bringing. There's pediatric care, psychiatric care, psychological and educational care that's provided. I have a slide for resources, just kind of summarizing the different resources for children affected by maternal substance use. And Taylor we can send out these resources if that's helpful for those here, if you would like them. These are some resources that may be less relevant for this group, but for adolescents with prenatal exposure. That should say adolescents and adults, young adults. We have resources for women and mothers who are misusing substances. There are a small number of programs in Georgia that are specifically tailored for the unique needs of women. And then we have some resources for youth with substance use problems, again, maybe less relevant for this group. But again, we're happy to share these slides that have the resources on them.